So I wanted to try to convey the importance of interviewing. I feel like I was watching the clips from the last time that I don't know if I was getting it across that like interviewing is not necessarily something that I do. It's not, I've done interviews. It's definitely not a strength or something that I've done a whole lot of. So I'm trying not to let that interfere with the fact that this is like a super important part of data collection. Like interviewing people and being able to have a flexible approach to gathering data has gotten us very far. I mean, a lot of things we know about psychology began in these sorts of ways, and then moved to more sort of quantitative methods with surveying and scales and experimentation and things. But without interviewing, without those things, psychology is sort of, it's sort of the good and the bad. Psychology sort of has this reputation of being this, soft science or not very scientific, and I think it's a lot because of these sort of interviewing sort of procedures or these sort of non-quantitative stuff that we do. But without a lot of that, the rest of it, probably wouldn't exist, right? So the last time we were talking about sort of the importance of sort of being able to not just ask questions, but be able to figure out, to follow up with very specific types of questions and get at the answers you want. So interviewers need to be skilled at sort of figuring out, okay, well, what other information do I need to get from this interviewee with the question and be able to follow those up? Because sometimes certain subjects, interviewees, are not the most sort of forthcoming with information. So you have to learn how to get this information you need by learning to adapt and ask the right sorts of questions. So one of the main things, responsibilities of an interviewer, whether it be a clinical psychologist or someone interviewing you for a job, is to try to keep the interaction sort of going, right? So if you're asking questions and the person really, will give you an answer and it sort of stops, to try to keep, a steady flow of information going, these are a number of ways that we're going to talk about in the next few slides, things like transitional phrases, verbatim, playback, paraphrasing, summarizing, clarifying, empathizing, and demonstrating understanding. So these are all different ways in which you can sort of help to keep the interview sort of going smooth and keep the person sort of talking and giving you information. So sometimes, you're probably the stereotypes of like clinical psychologists are like, oh, I see, and you've probably done this on the phone many times when you're talking to somebody and they just keep going on and you're starting to tune out a little bit and you just say things, right? You sort of say, that doesn't really help, right? So you need to be able to come up with sort of something more than just these things to sort of help sort of information going forward. Best to back up to something relevant to what the interviewer just said. So sort of this idea, and this goes with verbatim playback too, being able to reflect back to them that you're listening and being able to show them that you're actually attending to what they're talking about is very important. I imagine this is even more important when during a time like this when everything sort of moved to sort of telehealth, or you're doing interviews or sessions through Zoom, where there's more of a disconnection, these kinds of things are going to be even more important. Verbatim playback is a kind of technique that someone can use. Is literally just to, as people are talking about, you'll hear clinical psychologists say something like, okay, I hear you saying, and then they'll repeat back what the person just says. And it may seem silly. They may, you may get, there's again these like stereotypes you see in movies and things of people doing that. It seems like, why are they just repeating things? The idea is to make sure that the person knows you're listening. So if you can repeat back to them what they said, it tells them that you're listening, and it allows you to sort of further connect with the interviewee, so they know that you're following along and attending to what they're talking about. All right, it reinforces this fact that you actually are listening, because one of the main jobs of an interviewer, especially if they're like a clinical psychologist, is to be a sounding board and to listen to what the person is talking about. So verbatim playback literally means to say something back to them, almost word for word. That's where the word verbatim comes from, just to repeat back to them. to go a little sort of step further than that is sort of restating things in a different way, paraphrasing what they said, sort of to reflect back to them what they've said, but maybe using a different, different words. Okay, you're saying this, but what I hear, but I'm hearing, maybe, something like this. So it's a way of sort of paraphrasing and repeating back to them what they said, but in a different way. And sometimes that can lead to sometimes it's surprising that when you actually paraphrase back to them what they're saying, and they'll say, well, no, that's not what I'm saying. And it can lead to some growth, especially in clinical interviews, because they, what they think they're really conveying actually isn't coming across that way. And when you actually paraphrase back to them, they make them realize that, and they then have to rethink sort of what they're trying to say and what the information they're trying to get out. So this, it checks in with the client to make sure that you're interpreting the information correctly, and it gives them a chance to give you further information and make it clearer. And even if you do it in a sort of a larger way, you can start to paraphrase what they're saying, combined with some reflection, where you're now starting to give not necessarily your opinion, but you're starting to give some, you're summarizing, trying to put things together that they're saying, and being able to reflect back to them what's going on. So this pulls together the meaning of several responses instead of just repeating back to them about a single topic. Oh, well, you said the last time you're here, you said this, and now you're saying this, and those things. You're able to sort of put things together and try to help them integrate different ideas. So this is used to organize previous information, and it can be used to direct the interview. And as we'll see later on, it might point out places where the client or the interviewee is sort of contradicting themselves, which can then lead to further conversation about stuff that they are not being consistent about. All right. So clarification is another one. So if someone's saying something, instead of just reflecting back to them or summarizing or paraphrasing, sometimes you need clarification. You need to ask, okay, you're saying this, but I don't really understand why you're saying X, Y, and Z, and it helps to the person again to give more information to increase the sort of clarity of what they're trying to convey, and then to sort of to go even sort of further, you get this sort of reflection mixed with sort of empathy and understanding. So you're actually now putting in the fact that you actually, you're conveying them that you actually feel what they're feeling and sort of can understand what they're going through. And it verifies their feelings, that it's basically saying it's okay to feel that way. I understand why you feel that way. And it helps to sort of reinforce them going, through this process of sort of their feelings and how they are interpreting and handling what they're talking about. So instead of just rephrasing the statements and rephrasing what they're saying, you're now going through and sort of paraphrasing and reflecting back the emotions and the feelings, the state they were in while talking about what the topics that they're bringing up. All right, so it reinforces again that they're listening, but also it takes a little bit, getting into sort of really understanding and put yourself in their place and really trying to understand how they were feeling when certain events are taking place that they're talking about, or they're talking about experiences. That it really helps to be able to put yourself in their shoes, which can be tricky, and it takes some practice to be able to try to do this, especially with someone. Because you're not trying to understand them from your perspective, you're just trying to understand them from their perspective. And if someone has a very different viewpoint or is very different than you are, it takes some real practice to be able to put yourself in in their perspective, in their shoes, and their point of view, especially when it differs from your own. Right? So that's something that is sometimes a challenge for interviewers, to be able to put aside their own sort of perspective and be able to take another person's perspective and really sort of empathize with what they're doing, what they're going through. All right. So Carl Rogers had this sort of 5-point understanding scale that it was like, trying to quantify the level of understanding that the interviewer has with the interviewee. So levels 1 and 2 represent no or superficial understanding. So really getting into, just sort of surface understanding. You're not really getting into there. Level 3 requires enough understanding to be able to repeat back what the other person has said. Right? So this is what Carl Rogers said was the sort of minimum level sufficient for effective interviewing. You need to be at least at a level 3. Requires enough understanding for you to be able to repeat back what the other person said. So that's not even really understanding. That's just sort of listening and retaining information for you to be able to repeat back. And he said that's at least the sort of minimal level you need. Because if you're not really attending enough to be able to repeat back what they're saying, you're not really engaged enough in the interview to be effective. Okay. All right, so Carl Rogers said that at level 4, the response to the interviewee not only includes sort of accurate levels of empathy, right, where you're feeling what they're feeling, but the response adds noticeably to the interviewee's response, meaning you're actually helping the person to gain insight. You're actually helping them to sort of grow or to understand what's going on. So it's to empathize and understand so well that the interviewer, can state the interviewee's emotions as well, if not better than they can. So you're actually developing sort of insight into how the person's feeling, and you're able to sort of help clarify those things, help tell them, or help them understand what it is they're feeling and what they're going through. Level 5 responses include not only accurate levels of empathy, but the response adds substantially. Right? So level 4 adds noticeably, so you add a little bit of insight, a little bit of empathy that helps the person understand their emotions and things. And level 5 just takes that to another level. You're adding substantially to the interviewee's response. So the difference between 4 and 5 is more about the quantity, like how much you're adding to the interview process by empathizing with them and helping them understand their feelings. So that's sort of, we went through, let's go back a second. So we went through sort of how to keep the interview sort of going and keeping the flow of it going forward, and empathizing sort of is a big part of that, being able to empathize and demonstrate understanding. You can actually help then, because you can actually start to see where the person is going with what they're saying, because you're actually understanding, you're actually feeling what they're feeling, you're actually understanding what's going on. It helps us to keep the flow going. And then there are levels in which, Carl Rogers talked about sort of degrees of empathy and understanding that an interviewer should have. A bad interviewer, someone who's really bad at interviewing, is going to be at a level 1 or 2, where they're not really empathizing, they're not really trying to understand, they're not really even engaged or listening to the interviewee. And I don't even have here sort of how these are differentiated. These are bad. Level 3 is where you start to then are engaged enough to repeat back. And then you got sort of, as you add in sort of empathy to the process, and it allows you to understand and reflect back meaningfully to the interviewee, that you start to move from the level 4 to level 5 as you sort of add more to the sort of conversation. All right. So what are often the objectives? So when we think of interviews, and even I'm doing it now where I'm speaking about sort of clinical interviews, like psychiatrists or psychologists talking to patients, there's actually lots of different objectives, right? So the reason why someone comes in or why you're being asked to interview someone could be for a number of reasons. It could be simply family history. If you're a medical doctor and you're trying to get at sort of family history, if you're doing some kind of parental training, you may do an interview to sort of get at the objectives of the parents. Even just trying to figure out, how did they get here? What was the source of the referral, and why were they referred to you by this other agency or doctor or specialist? It could be, you're doing a interview about your child's sort of infancy, or their developmental milestones, medical histories. If you ever you've gone to see a medical doctor, they usually a lot of medical histories are done via paper pencil. They give you sort of a thing to fill out, and then it always sort of weirds me out a little bit where if you've ever gone to a doctor's office and you fill it out, and when you actually talk to the nurse, they'll ask you some of the same questions again, and you're sort of repeating yourself. And then when the doctor comes in, they'll ask you some of the same questions again. I'm always thinking, like, aren't you looking at the thing I just filled out? But I think a lot of that is not to burden you with repeated questions, but to verify that you are who you are supposed to be, and that they're talking to the right person, and that the medical history that's in the chart is actually accurate before they prescribe you something you're allergic to, You may have said, no, you're not allergic, and you may have absentmindedly done so. And then when they ask you, are you allergic? And you go, yeah, I'm allergic to penicillin or whatever. They're like, oh, and what you wrote down, you said no. So I think a lot of that is that. So sometimes the interview portion of that, where they're actually asking you questions verbally, is really to try to get accurate medical history. Even though, you can get into sort of more sensitive areas, sort of interviewing someone about a history of abuse, or their history of their treatment, whether it be sort of medical treatment or psychiatric treatment or something like that. Getting at sort of current behavioral concerns, just trying to understand what it is the person is trying to address in coming to therapy, if that's what's going on. And even sort of getting at, a lot of interviews will go at sort of, do people meet the diagnostic criteria? So if someone is depressed, there's full-on structured interviews about depression to sort of get you at a diagnostic criteria for depression. And the whole diagnostics things, gets a little bit crazy, and it's a little frustrating, because oftentimes the goal, a person, what they want is treatment. They want to get better. And sometimes it seems like the doctor, the psychiatrist, medical doctor, that kind of stuff, is really focused on trying to get you a diagnosis. And sometimes those two things they should go together, right? Your diagnosis should lead to the treatment. But there's lots of things sort of make that complicated. And I'm trying to get it here, but, for one thing, if you don't have a diagnosis, so let's say you're depressed, you feel depressed, and you want to go see a psychologist to sort of get treated or whatever, it's likely your medical insurance won't cover that kind of treatment. But if you get diagnosed as having, at least a clinical level of depression or something like that, you can then get treatment, but the only treatment they'll cover will be something like, a medical treatment, something like, Prozac or something like that, but they won't cover the counseling. And so it's a complicated thing. And so it's like you got the lawyers and the medical insurance companies. You also got the doctors, and you got the patients. Sometimes their goals are at odds. And, sometimes a big deal about going through the process is making sure a diagnosis of some sort is on the books, so that actually you can get medical coverage, which is a weird idea. You would think if a doctor says, hey, this person needs this prescription, then this shouldn't matter, but it does. At least, for a lot of insurance companies and things. There are 4 sort of general types of interviews that, most of these can be sort of, categorized in. You have the sort of evaluation and diagnostic interview. This is where, if you've ever seen even when you've gone to see a medical doctor, or if you've gone to a counselor or psychiatrist, a lot of the first visits, they're usually much longer, and you go through all kinds of different diagnostic processes. They're trying to evaluate you, trying to figure out what's going on, and they're not just trying to diagnose you or get diagnosis about your one specific thing. They're also trying to figure out what else might be going on. So they'll take medical histories, they'll take all kinds of things that are all part of the sort of diagnostic interview. Then you have things like structured clinical interview, which is once you sort of got past the evaluation diagnostic interview and you sort of figuring out what it is, what the issue actually is, or issues are, you're now getting to sort of more structured clinical interviews, where you have like structured interviews around depression, where they're trying to actually figure out ways to treat you and what's going to be the best sort of prognosis, depending on the different kinds of treatment. You have case history interviews, which exactly what it sounds like. You're getting at sort of medical history, family history, all that kind of stuff. And then you have mental status examination, which is different. This is like if someone is already hospitalized, there's already an issue, and then they'll give you different types of examinations to try to figure out what the diagnosis or something might be, or what their mental status is, depending on the different kinds of behaviors they're portraying. Okay. So, all right. So, an evaluation diagnostic interview is unstructured or maybe semi-structured. The idea here is you're as the interviewer, you're just trying to maintain an atmosphere of listening, facilitating, clarifying. It utilizes something called confrontation, in which the interviewer points out a discrepancy or inconsistency. So this is an interesting one. So it sounds bad, confrontation. So it's not like confrontation like you think it might be. It's more about they confront the interviewee with discrepancies and say, okay, a minute ago you said this is how this is how things are, but you're definitely saying you want to be something different, right? So, I feel depressed and this is how it is, but I want to be more outgoing, I want to be more energetic. You point out issues between what they say and what they do. So their opinions and what their statements may actually be at odds with their actual behavior. Something like cognitive dissonance, where you're actually behaving and believing in different things. And even pointing out that there are differences in their perceptions of things and the actual experiences they have. And sometimes you'll see this where a person will talk about a story or something will happen to them, and they'll explain it with a certain perception that that people are out to get them, or it seems purposeful or whatever. And sometimes the conversation will be something like, all right, well, what did you actually experience during that? So do you know that the person was purposely trying to hurt you? And try to point out where there are some inconsistencies or sort of jumps in sort of perception that may not be warranted based on the evidence of their experience. So these are all different ways in which they can confront where there's inconsistencies between what they're saying and doing, what their experiences are and their perceptions, things like that. And especially if they say one thing and do another, it's a good place to sort of start pointing out, well, your behavior is not really matching up to your beliefs and what you're saying that you believe in. So oftentimes details can be filled in later. The point of the sort of evaluation diagnostic interview is to sort of get at the sort of main sort of topics that you can then come back to and address in like a structured clinical interview or something like that. And this should only occur if data cannot be obtained another way, if time is limited and respondent is not cooperative, meaning that you can always fill in later with more direct closed-ended questions from the interview, meaning you can have them take a survey, or you can go in and get their medical files and fill it in. But the idea is that you actually should rely on further interviews, further things if possible, but that's not always the case, like if time is limited or if the patient just doesn't seem to be responding well and is sort of not forthcoming with information. So the structured clinical interview, so back up. So I said here a second ago that this is unstructured or semi-structured. So let's talk about what that means. So the fact that a interview is unstructured means that there, exactly what it sounds like, there is no structure. That person comes in, you're like, oh, why are you here today? And as they start talking, you start thinking about questions to sort of clarify what they're talking about. And it's a very unstructured. Sometimes you may have a set of things that in general you want to cover. Like, oh, I really want to talk about, their family history, or I really want to talk about certain things. That makes it sort of semi-structured. So you have certain topics you want to cover, but it's not a completely structured interview. So a structured interview is where you have a specific set of questions in a set order, combined with a specific set of rules as to how to probe. So literally you have a question, and then under that question, it'll give you possible, like, further probing questions, the kind of questions you can ask after that initial question to further probe if the person doesn't cover everything. But it actually lays out to you exactly how that should actually work. And it follows the diagnostic criteria for disorders defined in, I have this as version 3, which is, so it says, version 3 and later, that there's all this criteria that are put in here, starting in the DSM version 3 in 1980, that they started putting in guidelines for exactly how to do diagnostic interviews. And these, of course, have changed as the DSM has changed over the years. I know I went to DSM-4, and then I went to DSM-4R for revised, I think. And after that, I've not really kept track. Again, I'm not clinical. I don't really. The DSM is not something I really deal with a whole lot. But so it makes sense that if the disorder have If the disorders have specific criteria for diagnosis, a set of questions should help identify that criteria. But in order to do that, in order to have an accurate sort of diagnostic approach that can be used by anyone, right? Therefore, anybody that is trained to do this diagnostic approach can use it. You want it to be consistent, then it has to have a very strict set of questions and a very strict way in which the questions can be asked and what the follow-up questions are. You can't just go off script and do it. You have to follow a very structured process. Okay. So the structured clinical interview unfortunately assumes that respondents are being honest and capable of self-observation. This is one of the things that are interesting, that people are bad, right, at self-observation or at introspection. Right? Introspection is an awesome word that, let me sort of write it down, introspection. If you've never, I always write it right in the wrong spot. Hold on a second. I'm hoping all of you have heard of this term before, introspection, which is right, the ability to look, to look inside. Right, so this is your ability to observe or sort of look inside yourself and understand your own motivations, your own behaviors, that kind of thing. And as it turns out, most people are pretty bad at that, right? People aren't very good at introspection in general. Now, people can get better. There are certain people, and we talk, if you watch the intelligence lectures, where Gardner talked about an intrapersonal intelligence, which really are people that are actually good at introspection. They're really good at sort of looking and understanding their own behaviors, motivations, and things. They really have a good handle on who they are. So these structured clinical interviews assume that people are going to answer honestly to the interview, and that they're good at sort of self-observation. They're actually good at sort of looking at themselves, looking within themselves, and understanding what's going on. So one of the first ones you saw was a structured clinical interview for the DSM-3. And the other examples are a diagnostic interview schedule for children, the referral decision scale, diagnostic interview schedule, the Edinburgh postnatal depression scale. All of these are sort of examples of sort of structured clinical interviews that the goal then is to sort of, to help sort of diagnose things according to the DSM. So case history interview is sometimes called a biographical sketch. With open interviews, you can learn a great deal about a respondent and what is important to him or her. And case histories fill in the rest of the info that doesn't come up in other interviews. So typically is made up of primarily direct, closed-ended questions, so stylistically different as well. It's not like everything else. These are like, is your mother alive? Yes or no? And if it's yes, so it's a very, or there are specific responses you're looking for, and you're trying to get a sort of case history biographical sketch. Have you always lived in the same place? How many times have you moved? These are case histories, things, environmental factors, family issues, and stuff that can impact the diagnosis. Which is why when you think about the DSM, they have all the axes, axis 1, axis 2, and then one of them, I forget which, is around the sort of your environment and biological history, your general, it's like general medical issues or something like that. There's another one. It gets to the idea that those things that can exacerbate other psychological issues. So that's what they're trying to get at a lot of these with these sort of biographical sketch questionnaires. It's going to include things like work history, medical history, family information, other major life events. This could include, like with medical history, things like surgeries or other things, education, medication is probably part of medical history. Family information, like especially members that have similar difficulties. One of the questions you see a lot in a medical history is, has anyone in your family suffer from a mental disorder, or so the idea is if you have a parent, because a lot of medical issues like schizophrenia have a high heritability, meaning that there's a higher chance of someone in your family, like a parent or grandparent, if they have it, then there's a higher likelihood that you also have it. So they're asking those kinds of things. This also goes for general medical things too. If they know that you have a parent that has high blood pressure, you're likely then prone to it too. So they're looking for things like that. So there's often computerized. They'll have or done paper pencil, but it sort of lacks other facial and body language information that you might get if you actually did it as an interview. So you can see what kinds of questions make them uncomfortable, what kind of questions they really don't know, they're guessing at. That kind of information you don't get if you just have them fill it out and just have it or respond on the computer. Mental status examinations are used primarily to diagnose psychoses. So this sounds like the structured clinical interview, but you gotta remember, a structured clinical interview requires that a person be able to answer the questions, answer them honestly, truthfully, and be able to have some form of sort of self-observation to reflect back the answers. Well, if you have somebody that's sort of on the other side, they have some kind of psychosis, brain damage, or other mental problems, that may not be the case anymore. They may not be able to answer honestly or to give adequate self-observation and introspection. So there's things like the mini mental states, and there's other questionnaires or surveys or interviews that sort of cover this. But the examination includes info about the person's appearance, their attitudes, their general behavior, their emotions. Like, are they dominant? Are their emotions sort of appropriate? Are they fluctuating all over the place? Are they sort of emotionally flat? It does actually get an estimate of sort of their general intelligence and their ability to pay attention. It includes sort of all these things. But again, this is like you're trying to diagnose something like a psychosis or brain damage. These are sort of more things are going to affect lots of these things in different ways, but they're going to have an impact on probably a lot of them at once. That's why they're looking at a lot of this stuff all at the same time. So so we have two of these things really seem that they're getting at sort of diagnostics directly: the structured clinical interview and these sort of mental status examinations. One really is getting at sort of the kinds of disorders and things that may impair normal daily activity and stuff, but the person is able to sort of function for the most part. Here you're getting to a point where you're now talking about these are more sort of global issues that are going to affect everything and are probably impeding sort of normal, healthy interactions with other people, the ability to keep a job or to have relationships. So it's a different sort of purpose, all right? So this is really getting at sort of more issues with someone who's had a psychotic break or recent brain damage where they aren't able to pay attention anymore. They have radical fluctuations in emotions that they used to not have. Those kinds of things will help them diagnose along with other tests as well, things like brain damage or early dementia or other things like that. So I think it has a lot to do, if I remember correctly, not just this stuff, but relative to even a recent or relatively recent time, changes in appearance and changes in general behavior that have occurred. All right, so what about these are sort of other interviewing issues? And I mentioned this before, the interviewing is difficult. Like, again, I've done interviews. I've hosted focus groups, and I find it sort of really, really difficult to do. And it's to do a good job, you have to juggle quite a lot of information, do a lot of juggling all at the same time. You're trying to make the person feel at ease and sort of develop rapport. You're trying to think about what information you're trying to pay attention and keep in your memory things they're talking about, so you can repeat back and reflect information back to them. You're also trying to figure out, okay, well, what are they trying to avoid? What things are they, are they contradicting themselves? So you can actually use confrontation. So there's lots and lots of things to sort of keep in mind, right? So developing skills. Can you learn to be a good interviewer? So many rules and skills have to be together with a lot of practice. And the answer is yeah. I mean, you can be a good interviewer, and I think that people that are better interviewers are likely those that are just better practiced at it, right? They've done it more, they've learned how to do this, and it comes a little bit more natural. And so I think you can. It's just in the very beginning, you're probably going to be a pretty crappy interviewer. And it takes some time to really develop those skills. And you realize you have to sort of focus on developing likely one of those skills at a time. So I'm going to focus on, just trying to be engaged and really listening. And you realize when you engage in that and you're doing that one thing, you start to practice that one thing, well, you're probably not very good at then looking for things like inconsistencies in what they're saying, or being able to think about other questions you might be asking, because you're so busy focusing on the information that they're giving you, you're not really focusing on what information is sort of missing. So once you sort of get that practice, you can then start looking for things like inconsistencies, and you got to sort of work on these things not individually. You can sort of work on them at the same time. You have to focus on one at a time. Interviewer reliability. Inter-interviewer reliability has been reported to fluctuate wildly, and it's thought that this is because of differential goals. Right, so there's sometimes there are people focusing on the positives, people focusing on the negatives. We talked about social facilitation before. Even though if someone's interviewing the same person, they may be more reactive to social facilitation and stuff, and they're allowing the interviewee to sort of affect them, and they're reacting to that, and the social facilitation part. So there's lots of things that be going on. And the validity studies need to have the interviews focus on specifics, like on the details of what they're trying to focus on. Because sometimes if you're just focusing on the overall goal or these bigger picture things, sometimes it may seem like they're similar. When you get down to the specifics, the interview reliability starts to sort of fall apart. So this is harder, and again, I think it also has to do with the differences in quality of the interviewer. Better interviewers matched with people who aren't as good, you're going to see very different outcomes, very different things. It's going to look like they're not very reliable. Even with structured interviews that should be more reliable, oftentimes aren't as reliable as you might think, because there's just a lot of subject variables involved, because the interviewer, think about all the issues we have with people as judging, looking at doing behavior assessments. You have that with interviewers, but you also have them affecting the flow of the interview. So, there's a lot of things, at play that are going to change the outcomes of an interview that can really sort of wreck the reliability. So, part of the issues, things that affect the validity of an interview. One of the things is called the halo effect. So an evaluation made during an initial interaction clouds later evaluations. So I'm not really sure why it's called the halo effect. It sounds like it's called like primacy effect. I think of this as sort of primacy. So it's a sort of form of primacy effect. You think about first impressions, that when you're doing a set of interviews with a client or interviewee, it's that things that occur early on, an evaluation made during an initial interaction will then cloud the remaining interactions. So if someone comes in, they're rude or whatever, they're I don't know, they seem disorganized, whatever the issues are having that first initial interview, well, then you'll assume that that's what they're like, and everything they do after that will be interpreted through that lens, through this sort of halo effect. Now, usually it's done, the reason it's called halo, I think, is because usually when someone comes in early on and they seem fine, they're putting out their best, projection of themselves. They seem totally fine. Well, as they start to open up and show more of the issues that they're having, and the person's getting a little bit more insight into the depths of the issues that are going on, they sort of recall that initial effect and may actually underplay or downplay the issues that are happening because of that initial halo that they were given by that really positive first interaction. But it's still called the halo effect, even if it's negative, which is a weird one. I think of this as we tend to remember things that happened during our first encounter. So this is a primacy effect. The things that happen early on, we tend to remember more. There's also one called versus sort of the latency effect. or this is things that, the last thing that occurred, like things that happened more recently, you'll remember more, or primacy, things you remember that happened first. So this seems to be a type of sort of primacy effect where the things that happened early on in evaluations tend to cloud the rest of them. Then you got something called general standoutishness. So there's one primary characteristic that causes bias and prevents objectivity. So grooming or attractiveness or other things that will completely overrun the rest of the interview or the rest of the set of interviews. So again, if a person comes in and they seem with grooming, their hair is messy, they're not dressed for well, they got stains on their clothes, or whatever. You may not be able to get past that to see that really underneath they're actually very intelligent and they have other things going on. It's just that there's one giant, overwhelming, looming sort of trait that maybe a person comes in and you just find them remarkably very attractive. You may not be able to get past that attractiveness to fully sort of listen and engage with them, because that one trait is actually standing out and it's causing issues. It's causing you to be biased in your assessment of all the other parts of the person. Trying to get another one. This also works in getting into culture. These two can sort of overlap somewhat. I was thinking about imagine if you're you have an interviewer that's very Christian. They're very religious in the Christian faith. And someone comes in, and as they're doing the initial set of interviews and stuff, the interviewee, when they ask, what religion or whatever, and they're like, I'm an atheist. That one characteristic, because they're an atheist, and the Christian therapist's belief about atheism and other things like that may completely cloud the rest of everything that person does based on that one standout trait. Okay, so as an example, this goes for lots and lots of other things, and you can see how it sort of overlaps somewhat here too with culture. Can an interviewer from one culture accurately evaluate a respondent from another culture? There's all kinds of issues that happen with culture that you'd have to sort of understand. Where, for instance, if in a lot of cultures, maintaining eye contact is actually seen as negative, and smiling too. One of the things, if you ask people from around the world that are sort of strange about Americans, is that we're always smiling at each other. It's sort of seen as a weird trait that Americans do. So maintaining eye contact can actually, in some cultures, be seen as sort of threatening and other things. So in other cultures, if you don't maintain eye contact, you'll be seen as rude. So there's going to be a lot of sort of cultural conflict that can occur if there is a mismatch. And there's lots of research to show that there's lots of cultures that don't seek mental health professionals very often, and one big part of that is because there's not enough of mental health workers like psychiatrists, psychologists that are within their own culture for them to go and see. They don't want to go and see somebody from a different culture. So there's all kinds of issues that happen with culture. But you can also tell too that the culture can lead to this sort of general standoutishness issue where there can be some certain part of their culture. Again, look at eye contact. They maintain this like very hard eye contact with you the whole time, and from your culture that's seen as sort of threatening or aggressive. You may not be able to get past that one sort of trait and actually accurately assess the rest of them. But this is actually getting at not like the reliability from interviewer to interviewer, but really like how effective, how valid is the actual interview or the set of interviews when someone's trying to diagnose or someone's trying to get an idea of how to treat a person's problems. These kinds of things may actually affect their ability to accurately, validly sort of assess them.